going to be recording this section because we do make it available for people afterwards. So we do encourage you to put your camera on if you can. And we do appreciate people's internet isn't always stable, and if you prefer not to, that's fine. If you introduce yourselves in the chat, that's great. And I'm going to just hand over to David, who will introduce himself and his discussion. I think if you've got burning questions as he goes through, he's happy to take them. Otherwise, we have a discussion at the end. So, David, thank you for agreeing to come and present tonight. Over to you.
No problem. Thank you and welcome all. So my name's David Farnsworth. I'm the Assistant Director for Community Services with Powys Teaching Health Board. For colleagues who aren't familiar, the NHS is in Wales divided into health boards as opposed to provider trusts. In Powys, we're a mix of a provider and a commissioning organisation, but I head up the adult operational services. And I was asked tonight to talk around our work to strengthen our teams using international nurse recruitment. So, as I've said, there are a number of colleagues who may not be as familiar with Wales and the NHS in Wales. So, Powys, which is the county highlighted in red there, largest county in Wales by land area, obviously central Wales and quite considerably bordering England, which is very relevant for us in terms of our workforce and indeed our patient population. Predominantly mountainous and rural, and in terms of population, one of the lowest densities of population in the UK, which again is quite significant for us. Represents a challenge for delivery of services, but also in terms of how we recruit and operate our workforce. It is a predominantly white British population, which again, in terms of reliance on overseas nursing, is of relevance to us. And an ageing population with a particularly high proportion of residents aged 65 plus, and indeed often some of the population that are highest proportion living on their own, which again is interesting for our delivery model. Main languages being English, but there is some Welsh spoken in the north and the south of the county. And our economy predominantly agricultural, tourism, and public services. So it is a very different county from a lot of other places. And you will see in the top right corner, that's a picture of Pen y Fan, which is one of the mountains in the Brecon Beacons, and a slide that we use as part of my work. The organisation has a number of slides which it uses when we are on Teams presentations. And if you take me to the next slide, please, Eleanor. That's another one of our slides. And I guess probably it's simply there to say it may be very rural, but it's also very, very beautiful. It has its attractions, that's for sure. So if you jump onto the next slide, please, what I'd like to do really is just talk through some of our challenges and some of why our reliance on a recruitment outside of the country is something that has been needed for us. So if you jump down to the next slide, please. So our workforce challenges we've set out here is significant. As an operational service in relation to community hospitals, and obviously we've got a number of other services that we operate, whether that's the traditional community hospital services, we've got 2 operating theatres, associated outpatient departments. We've also got obviously a significant number of therapy services, and we repatriate our patients back from a number of counties where we've got discharge teams. So we've got quite a big offer, but in terms of our locations, the blue dots represent, the blue dots represent, the blue squares represent our community hospital locations. So we've got 9 locations, 9 county towns where we've got wards, some larger than others. Some are as small as 14 beds, some are as large, if you count both wards, as nearly 30 beds. So from our perspective, it's a very wide and varied model. We do have one community hospital which is designated in East Radnorshire, which is Knighton, a place called Knighton, though that no longer has any beds. However, the building itself is also co-located with a residential home, which unusually for NHS we operate, which is something that's also helped us shape our model, our offer around community hospitals, but I'll come back to that. So as a snapshot in terms of our registered nurse establishment within the community hospitals that we've got, you will see here down on the right hand side that the levels of vacancies that we can carry in our registered nurse workforce within these locations. And that's not insignificant. Now, as a result of that, we have to think about how else can we cover our workforce gaps, because there are set established workforce levels required of each and every shift. So as it stands at the moment, for most of our community hospitals on each shift, we have at least 2 registered nurses, which isn't very resilient when one is unfortunate enough not to be able to come into work. But we also have 1 or 2 that do have a large enough area to have more than 2 nurses. And even within that, our workforce population is not where it needs to be. So as a result of that, we have some challenges. If you move us on to slide 6, please. You would expect me to say that as a result of that, we are therefore reliant on a high level of agency. And within Wales, there is an agency framework, which I am guessing there will be in the majority of the UK, where we have some agencies that are signed up to lower costs, called on-contract agencies, and some that unfortunately won't commit to those lower costs, and they are off contract. And we have over the years had to rely on a very high use of significant off contract agency staffing, which is expensive. It is poor quality. This is no reflection on an individual nurse, but if a nurse is coming to work and they've never worked in that environment or that place before, as well as possibly having less commitment to that workplace, realistically their knowledge and skills won't necessarily be ideally suited to that particular cohort of patients, and that can prove to be a challenge for us as well. So it comes with its quality and safety implications. Colleagues will also know that there are a significant number of reports which recognise the limitations of our nursing workforce. So, I cite here a number of news articles or professional reports on where areas where we are seeing a far lower level of our own nurses. As a result, the Health Board has put in place its own Health and Social Care Academy. So we are obviously trying to build our own, we're trying to grow our own nurses. We have an aspiring nurse programme where somebody can come in as having had very little experience of providing healthcare, as an unregistered member of our team, a band 2 HCSW, healthcare support worker, and we can, through the academy, grow them right through to the point where they can enter into their registered nurse training. In fact, as it stands at the moment, in year 1, we recruited 22 candidates into that. We're now just from memory coming into year 3. And we similarly in year 2 recruited a similar level of staffing. So we are expecting to be able to put through to registered nursing training a significant number of nurses. but that still leaves us big gaps. We're targeting our retire and return staffing, but again, that makes for some real challenges in the fragility of our workforce, so we need to make that much more stable. So let's move on to the next slide. And this is where we then start to reference the fact that we are now, in essence, moving towards the need for accessing international recruitment. Now, Wales was, I think, very proactive as an NHS system in identifying that we need to organise the way that we approach international recruitment. And to be fair, the Welsh Government commissioned the International Recruitment Programme in 2021. And this was how it was looking to help inform and organise all of our recruitment across Wales. If I am recruiting the same nurses as everybody else is recruiting, and we are fighting each other for those nurses, that's not going to be advantageous to the health system of Wales. So they agreed to put together a coordinated programme with investment, which would allow the health boards to start to access that. And the aim is to appoint, the stated aim was to appoint 422 registered nurses across Wales. So by March 2022, 413 offers for recruitment were made, which is a significant success in the international programme. And in fact, to standardise that and to formalise that, an MOU,
I'm responsible for the ships for 16,900 horsepower engines.
There's obviously some noise off. That's okay, thank you. So a formal MOU was made with the government of Kerala, and there was a further recruitment event in May 2023, appointing a further 58 RGNs. And it was this Once for Wales approach in standardising it that helped make our access to this system much, much easier. The numbers that we wish to recruit, whilst for us are significant, across Wales are much less significant, and giving us a platform which allows us to improve our ability to compete for these candidates in the same way that the other health boards can. Whilst we can't offer an environment which might be competitive around, for example, nurses who have ITU experience or A&E experience, we certainly are looking for nurses who have a level of skill and capability which is more suited to our rural community environment. And of course, in Kerala, there are a huge number of nurses who themselves live in very rural areas. So as a result of that, we felt that there was an opportunity for us to build on that. As you've seen there, Wales has made a commitment to further international recruitment, and importantly has financially primed that work. And that's important. We have to recognise that the health boards, including ourselves, couldn't have done this without that investment, because bringing people to the UK, training them and supporting them in their initial settlement into the UK is an expensive business, and that has to be recognised. So if you move us on to the next slide, please, and really this is just a point where we're showing how we are doing it specifically in Powys. So jump on to the next one, please. So as an overview of the process, the health boards have to make a commitment to an annual recruitment plan. So we have to set out how many nurses we believe that we can accept over the course of the year. And realistically, when we started this programme, we were looking to bring in around 20 nurses a year in order to close some of the gaps in our workforce. The way it worked was that the NHS Wales commissioned commissioned an agency rather, to supply the candidates. So There were centralised recruitment events organised in Kerala. The health boards were required to put forward nurses, senior nurses, to undertake the interviews and to select recruits who would be appropriate and suitable for training in the UK. And we participated in those events through my operational nurse leads and indeed our training and education team participating in recruiting those individuals. And those events, as well as being attended by ourselves, were also attended by the HR teams, whereby therefore interviews can be undertaken as a single event along with those initial recruitment checks. Over the course of the following weeks then, the agency then undertakes the relevant immigration checks, and in the meantime, assuming those candidates were felt to be suitable, notional appointments were made, and then the health board is required over the course of the year to work out in what order it brings those individuals across in terms of numbers, locations, and what the onboarding plan is over the course of the remainder of the year. For us, that was very much a team effort. So our HR team led on the initial process for recruitment, but required nursing and operational teams to come into that for the recruitment. But we recognised early that we would also need a range of other skills, including colleagues who can help with organising accommodation for these individuals, pastoral care, and a number of other specialist teams who might be needed to help with the process of bringing these individuals into the UK, training them and supporting them through their UK examination process. So if you move to the next slide then, please. So we then, just to extend this, initially started with the HR team running what essentially was an operational process to bring these individuals into the UK. It became quickly apparent that we were likely to experience some challenges, and I'll talk about that in the next slide. But what that really needed was some operational ownership. So the HR workforce leads came to myself and said, well, they identified that whilst they were capable of helping with the logistical processes, they needed the operational teams locally to own and support the induction of these individuals into our teams locally. Because for us, this is about how we bring somebody in and make them feel valued and part of a team. And it's the operational team, the day-to-day team in the community hospitals, who will be important to the welfare and support of those individuals. And rather being done to by a very anodyne HR process, what they wanted was, quite rightly, some operational ownership and some engagement and relationships with the operational teams, which would help provide that. And I was asked to take a lead on the operationalization process. So by bringing in a regular meeting to review the processes, the individuals, the performance of where we are in bringing these individuals across, we started to get some cohesion between the various teams that were needed. So the immigration status, Catherine, and we'll pick this up towards the end. I can't see all the comments apart from when they pop up. But the immigration status is that until they achieve their UK registration, they are essentially in training, and their permanent resettlement, or indeed their work visas, are conditional to their successful completion of the examination process. And in terms of allocation of home leave, yes, they are, but I'll come back to that because that is a challenge as well, but I'll come back to that. So they come over with a work visa, and they come over with a right to reside in the UK, and as I say, all of that is conditional to their successful completion of training, after which, should they choose, they can also then bring family, which is again something that is relevant to this. So the team that come together to do this was myself as the operational lead, a recruitment lead, training leads, the estates team, and I'll come back to that. So our estates team aren't responsible for accommodation, if you like, but they recognised early on that they need to help us with that. And the teams from the ward. And what happens is that once the individuals are across, we provide a 6-week local training program. And that includes a practice for their OSCE, their Overseas Certification Examination process, which is held in Leeds. So they have an examination that they have to travel to Leeds for after around 6 weeks. And we coordinate that by, we have to pay for the examinations, we have to organise their transport to the examinations, and potentially where they are staying, accommodation as well. So it's a fairly logistical intensive process. Once over here, within the course of their 6-week training, after 2 weeks, we will have completed their health clearances, giving them permission to then enter onto the ward and to working on the ward, and the shifts are then balanced. So a number of shifts are then balanced with their training program over the course of a week. They're recruited and employed and working at a band 4 level. So for colleagues who aren't clinical, essentially band 5 is where you start in the NHS with your registered nursing qualification, and they are working as a, if you like, a very senior healthcare support worker, or the equivalent for those who would recognise the history of the nursing practice of an enrolled nurse, something that a band 4 role has been developed in the UK now, and they work as that until their PIN number comes through. So they are successful in their qualification, and that the NMC, the Nursing Midwifery Council, appoints them to the register. So you take me on to the next slide, please. So for us, the biggest issue, which was unsurprising for us, I guess, might be for others, is accommodation availability. Within the model for Wales, we are required to provide 1 month's accommodation for the individuals, after which they are expected to find their own accommodation. For those of you who know Wales and rural Wales, you might recognise quite quickly that's going to be quite challenging, especially in the market for rental properties in the UK at the moment. But in the context of Powys, you cannot believe just how time-consuming and problematic this rapidly became for us and for the nurses themselves. So when they come over, if we were to say to them, we'll accommodate you for a month, and we've got very limited accommodation of our own, we've got a handful of staff property, if you like, which is for training. So the student nurses, where they rotate into our wards, and one of our locations, which is Broncleys, right in the middle of very rural Powys, and with very limited transport, public transport, potentially we could accommodate them there for them. But after that, they would be expected to find their own accommodation, and that's just not going to work. So the health board took the rather unusual and very different step of agreeing that we would secure their property for a year, up to a year, ideally 6 months, by which we would make the initial contract. We would pay the first month, and then as part of their induction and bringing into our employment, we would expect them, the individual nurses, to then take over the contract that was initiated with the landlord. And that was the only way we could provide them accommodation, because otherwise we would have found that after a month they wouldn't have accommodation. Even doing it that way has resulted in us having to find property for individuals, and when they themselves chose to move on, the health board has had to bear that cost, recognising that the circumstances of the individuals have changed. So, for example, once they have qualified, many are focused on bringing their family across, understandably, but we try and encourage them to remain in the property, mindful that we have made a commitment to the landlords on behalf of the individuals, whilst the individuals themselves are paying those costs. If they are fortunate enough, and that's a challenge, to secure an alternative property, we would be left with a stranded cost of that. And to a degree, we've had to bear that as a cost to bringing these individuals back to the UK, because otherwise we would find that they would be left without any accommodation. And it wouldn't be appropriate for us to bring people into the UK, organise them for a month and say, do you know what, it's up to you now, sort your own accommodation. We've had whole teams working on this day and night at some points, and I do mean at night, because I had to go and visit local properties to try and find accommodation. I cannot emphasise just how time consuming and how much effort it has taken to secure property for these individuals in the locations where they will be working. To the point where even complexities such as when they are organised to come across to the UK, so before they arrive in the UK, the usual process for moving into a property is that a landlord would say, fine, so through an estate agent, fine, not a problem, introduce us to them, and then they'll have to sign a contract. And they can't sign a contract because they have no right to reside in the UK until they get here. So it's proved to be hugely problematic, and we have, as a health board, have said, fine, we'll sign it. The landlords often aren't interested in going to a commercial organisation to sign their leases, because they can more easily go to the usual route of local population who are saying, no, we'd like to move into that property, please. For every person that wants to move into a property, there's usually about 10 others desperate to find it. So we've fallen to the bottom of the list very quickly. So we've become experts in developing the market. We have worked with Airbnb owners to convert their properties into houses of multiple occupation, HMOs, so that 3 people, 3 nurses, could then come and live in the house with 3 different leases. We've had to set very, very, as I say, firm ground rules and set expectations with these individuals to say, once you're in these properties, we are asking you to stay there, because otherwise we would struggle with that. We recognised we needed to put in place a welfare role. So that was hugely important. Having a group of people who are responsible for resettling these individuals was all well and good. But if the training team look after you when you're in training, or there's somebody in estates trying to find somewhere for you to live, who do you go to when you've got a problem? Who do you go to when you don't know how to set up the heating in the house, or don't understand where the nearest bus is? So what we identified is we needed to put in place a welfare role, and very quickly we identified an individual who was able to step into that role, and we created a job, we created a job description, and we got them to apply for that, or we asked people to apply, and this individual applied, and they were successful in picking it up, and they have become the right hand of these individuals, the common, the regular face that they see to help them do this. They help set up bank accounts by supporting them to get to the bank. They helped them to collect what were their BRP cards when they first came to the UK. The process has changed now, but you had to go to a post office, often a matter of 50 miles away, to collect a card which was issued to you by the Home Office, and you had to collect it. You couldn't have it posted. So that you had proof of your right to residence in the UK. And this individual helped organise how that could be facilitated. They help organise the nurse examination arrangements, the accommodation troubleshooting, and as I say, right down to how to set up the heating. And even some community integration events. We've had a number of areas where the community have asked to receive a group of individuals from the overseas nurses who are settling in their community into community events. The individual who holds that post has helped coordinate some of that, which has been really helpful and certainly well appreciated by our team. Training locations, not always easy. We've trained our teams in rugby clubs, in hotel conferencing rooms. We do have some accommodation ourselves, so we have used our own training rooms, but not always suitable. And when, for example, you are training on things like our hospital equipment, including hospital beds, so a hospital bed these days isn't just a lump of metal. It's it's plugged in, it's programmable, it's got mattresses. When we are trying to train on that kind of equipment, it does mean that these individuals need to be able to use it and see it, which means we have had to transport this equipment into places where it's needed to be kept for a matter of weeks. So making those arrangements has taken some thought and some planning. And then this has all been overseen by a weekly touchpoint meeting by everybody involved to run through where are we today with our current cohort of individuals in terms of organising their training, in terms of troubleshooting, what they need in terms of their accommodation, or whether this is an individual who's struggling to pass their OSCE examinations. They get up to 3 attempts to pass their examinations. And I'm delighted to say that all of our nurses have been successful over the course of their training, which is something that I think is a credit not only to the training team, but to the ward team who've supported them through that. If we take me on to my last slide, and we can take any questions after that. So yeah, we have seen some significantly positive results. From 2022 now, we have recruited successfully 41 nurses from Kerala. And unusually now, we have started, and Wales has commenced a programme where we are inducting now mental health nurses. So we've taken 6 mental health nurses. Not quite so straightforward, because their local training or their mental health training can't be delivered locally, rather. It is being delivered centrally in Cardiff, which adds a layer of complexity to our local arrangements, but something that we've been successful in doing. We have 100% success in passing examinations. Only a handful have needed to go on to a second examination. None have had to take 3, which I think is a huge credit to these individuals who've moved all the way across the world, often on their own, often with very little support, and have demonstrated massive personal resilience, professional capability, and have taught us huge amounts about how to improve the quality of our own care. And I have to say their contribution now to teams locally is absolutely overwhelming, and they themselves are moving on in their careers. Several of them now have moved up to more senior roles and have successfully contributed to the success of the organisation, which I'm hugely grateful and proud of. They have helped us massively reduce our reliance on agency staffing. In some areas now, we are fully established in terms of our registered nursing, which, if you remember those earlier numbers, is a massive improvement. And again, you see huge positivity from nurses and the local teams. They have become a very important part of our workforce, and we don't see these individuals anymore as part of our overseas nurses team. We see them as part of our team, and that for me is a huge success. Going back to those earlier questions, yes, they can go home, and we had to navigate some rather sensitive queries within the Home Office around what was and wasn't allowed, but they are allowed to go home as part of their visa requirements, and we are currently organising their leave in a way which maximises their welfare, but hopefully improves their overseas breaks, so back to see their family. In the organisation, in the NHS, it's around 6 weeks annual leave allowance. You get a year. We encourage them not to take more than 3 at any one time, but we're comfortable that 3 is, whilst it's an unusual level of break at the same time, is something that would be needed for them to travel home. But we do want them to also make sure that they don't, if they were to take it all and not get any breaks during the year, that would be a problem. Most have chosen to bring family over and they move on from their temporary accommodation. That in itself can prove to be a problem. They need to secure that accommodation for themselves, and the market is still challenging. Are we still actively recruiting them? Yes, albeit in much lower numbers. 25-26, we have actually only recruited 8, and we are currently looking to organise the first cohort to come across for training towards the latter part of this year, around November. But actually, I'm now running into a slightly bigger problem, which is previously I've had locations, for example, one hospital, where we could then bring all of those nurses at the same time. Actually, now I've got a problem where I don't have that many vacancies in one location, so we're going to have to work out how do we do this over a couple of sites to be able to do that. So it's again going to add a layer of logistics, and I'm nervous about the support that they gain by coming together and working together and training together, and in fact ending up on the ward together. They could lose if we fragment them and move them across multiple hospitals. So we're going to have to think about how we do that. I think I've answered most of the questions as they've come. Can they apply directly, or do they have to apply through an agency? Yeah, they can apply directly. It gets a little more complicated in terms of the recruitment process. Because often health boards and organisations aren't particularly well set up to navigate all of those visa requirements and all of the settlement requirements. And we couldn't create a program like this for a single individual nurse in the same way that is easier for us to do for larger cohorts of nurses. And coming through an agency also offers its other advantages because they sort out a lot of those issues. So there are pros and cons to both, but recognise that they can apply directly.
David, there was one question in the chat about have you any experience of integrating refugee nurses?
No, we don't. I'm trying to think actually whether that's true or not. I don't think we have. Obviously, Powys do have refugees, and not to my knowledge that any of them have joined the health board. But the reason I hesitated is I do know that we had one interested person who was making those inquiries, but we never went through to recruitment of that individual. So not to my knowledge, but again, I mean, it's not something we would roll out. And I would guess that in terms of refugees, because they are already in the UK, making those arrangements, notwithstanding the navigation of the work rules, would be somewhat easier though. Yeah, thank you, Catherine. It is an impressive programme in the sense that, I mean, you know, let's be honest, the Welsh Government have made that very much easier for us, although what I cannot overemphasise is the amount of time and commitment that my colleagues in HR, in particular estates, and my welfare officer have put personally into this work programme. It is huge, and it is that collective commitment that has been really, really impressive. 6 weeks OSCE preparation. So is the 6 weeks? Yes, it is. So we bring. So the way that we've worked it is that in terms of the actual programme, the agency, we make arrangements with the agency to book flights once we know we've got the accommodation in place. We bring them across once the accommodation is available, let's say in groups of 4 on average. From that, we bring them across. Well, we started bringing them across pretty much at the same time as we started the training. We realised it could become very disruptive. There was a settlement period. There was all of the administration that they needed to follow. So what we've taken to doing is bringing them across roughly a couple of weeks before training starts. The first week, as well as a bit of orientation, is about making sure that their settlement in their property is fine, getting their bank account set up, getting them through occupational health. In the second week, we tend to then commence the introduction to the ward, commence the introduction to the training team. It's then usually a fairly intensive 6-week period of training, including in the latter week the trip across to Leeds for the OSCE training, and then obviously we get the results of the OSCE training usually within a matter of a handful of days or a week afterwards. And at that point, we know whether they need additional training. We can always put them back through that with the training team, individually or otherwise. On the occasions where all of them are successful, they move straight onto the ward. But by that time, after week 2, they would have had a relationship with the ward anyway. So that's helpful. Yeah, do I think that the fact that it's rural and isolated has helped? In terms of settlement, again, pros and cons. I think we've spoken to individuals, and some of their feedback. I cannot emphasize just how positive their feedback has been, but some of their feedback has been very much around the fact that there are comparable environments to home in terms of that rurality and that living in not living in cities. But it comes with its own challenges. Many of them can't, most of them, in fact, I don't think any of them so far have been able to drive. Reliance on public transport in rural UK is, I think, probably ironically from the anecdotes I've heard, worse than it is in rural India. And from our perspective, that isolation could be problematic. So coming together with a larger number of individuals sharing properties has helped offset that. But there, as I say, there are other issues around living isolated rural locations. We've based them, obviously, for obvious reasons, in market towns, which aren't immediately rural in the sense that at least there are some facilities within that town. But even in the context of urban environments, they are not urban, and there are a lot of things they are missing as a result of that.
David, I just want to say a huge thank you, because that was an absolutely fascinating presentation, and just so interesting to hear, how it all came together, but actually then the nuts and bolts of what you needed to do to make it work. And I think anything that results in 100% retention deserves a huge round of applause and a real amount of praise for your team.
Definitely applause, but thank you.
Thank you very much for coming and presenting. Thank you everybody for attending, and have a great evening.
Thank you all. Take care.